Respected senior colleagues, my dear friends, at the outset, I should thank the entire organizing team of WIMS Wayanad for giving me an opportunity to be part of this wonderful conference. Extubation, like intubation, is a very critical step in our day-to-day practice, but unfortunately less often described or discussed in the academic fora. So my idea is to generate some interest in the topic. Our day-to-day practice is often described as got a lot of similarities with that of aviation industry. As you know, the mishaps can happen during takeoff and landing in aviation industry. And it's often said that the mishaps is slightly more during landing than takeoff. So also in anesthesia, as we found in an apricot study, which was released in 2017, which is a large study in an cutting across 261 major institutions in Europe involving pediatric extubation. So they have found that most of the airway-related incidents like laryngospasm, bronchospasm, aspiration risk, or stridor do happens more than during extubation than intubation, as you see, as is obvious from this chart. So it was aptly described by Murray DJ as an art than science. Yes, of course, the extubation, for a successful extubation, it involves not only the knowledge, but also the skill and expertise of the anesthesiologist. So what is extubation? It's the purposeful removal of the tracheal tube and transition from an artificial airway into a natural airway. And actually it should be a planned procedure as in case of an intubation. And extra care has to be there for difficult extubation, difficult airway scenarios. And in the event of any difficulty you have encountered during extubation, you had to document it properly for that it would be useful for future references. So what are the crucial issues which are likely to encounter during extubation? You can have dysfunctional airway reflexes, either exaggerated or reduced reflexes, or depletion of oxygen source reserves, or can have airway injuries during extubation, or physiological compromise on the cardiovascular system, and sometimes equipments and assistance not available at the time of extubation. Most of the time, for a difficult airway scenarios, at the time of intubation, you will have all the human resources, equipments, and monitors readily there for you to help you. But unfortunately, during extubation, you'll be alone to face the extubation. So you need to have a meticulous planning, and you have to assess the airway at the end of procedure. Will the child be able to cough and protect the airway at the end of procedure? Or the medical or surgical factors as optimize the airway? All these things you have to look into at the time of extubation. So if you have a difficult intubation, that means if you had a difficulty intubation, that means invariably there will be a difficulty. You will have a difficulty in during extubation most of the time. So also multiple intubation attempts and distortion of the airway as a consequence of surgery, and restriction of the airway access following the surgical procedures, and sometimes edema due to prolonged surgery of the oropharynx. I will give an example for that. So this is in a child with a very anticipated difficulty airway during intubation and extubation, as you can see in a PRE child. This is the child I mentioned. These are the two scenarios we have encountered in our hospital, wherein both these children didn't have much difficulty during intubation, but unfortunately during extubation we faced a lot of difficulties because of massive tongue swelling. Obviously, because that time it was under retractor for a long time, both of the childs were doing and palatal surgeries. So AIDA, All India Difficulty Airway Association, has identified 4 Ds and 3 S's for anticipated difficulty extubation, as in whether you have encountered difficulty mask ventilation or difficulty in intubation or re-intubation, or there is a delayed recovery at the end of procedure, difficulty because of pre-existing diseases, or a surgical cause of airway compromise, suspected airway edema at the end of procedure, or suspected airway collapse. So all these scenarios you can anticipate a difficulty extubation. So you have to meticulously plan the extubation. You have to empty the stomach, and you have to timing the extubation. And also you have to you need the monitors, proper monitors during extubation, and you have to plan the plane of extubation, whether you want a awake extubation or deep extubation at the end of procedure. So why you have to empty the stomach? Because during intubation or during mask ventilation, some inadvertent air gas may entrap into the stomach, and you have to suction it out when the child is still deep under anesthesia. For that, you have to use a properly lubricated, proper sized catheter, which will invariably reduce the risk of aspiration. And especially you have to do this in a full stomach scenarios, and it will definitely facilitate the expansion of lungs, improve the FRC, and decreases the atelectasis at the base of the lungs. So child is more likely to desaturate than adults, so that you have to keep all the monitors during extubation what you have used during intubation, and you need to have an arterial saturation monitor, pulse rate, electrocardiograph, and capnograph. You can extend it even after extubation. So what are the complications associated with the extubation? You can have upper airway obstruction, apnea or breath holding spasms, aspiration of gastric contents, bucking, bronchospasm, or even laryngospasm. I'm not going to detail of all these scenarios, possible scenarios, but to say that there is a 3 times higher incidence of laryngospasm in infants than in older children. And a recent upper respiratory infection or asthma is associated with 2 to 7-fold increase in incidence of laryngospasm. Now, the question is that how long you have to postpone after the child following upper respiratory infection. There is no definite answer, but the consensus is that there will be a decreased of incidence of respiratory complications 2 weeks after recovery from the respiratory infection. And most of the time, the precipitating force for the laryngospasm is a noxious stimuli, which inadvertently stimulated the child in a lighter plane of anesthesia. And what should be the plane of extubation? For that, you have to answer, was there any difficulty in controlling the airway at the intubation? Or is the child is under risk of pulmonary aspiration after extubation? If the answer to both these questions is yes, then it's better go for awake extubation. So you also have to consider the surgical requirements for the plane of extubation, like in neuro or ophthalmic surgeries, where you don't want the child to buck at the time of extubation, and the preference and choice and expertise of the anesthesiologist, and the facilities available for the anesthesiologist. And the deep extubation cannot be entertained when a dedicated postoperative care is not available. And evidence is mixed regarding the adverse events between the awake and deep extubation. And what are the criteria for awake extubations? Most of the anesthesiologists prefer to have the child awake, fully awake after extubation. For that, you have to, for awake extubation, you need to have adequate tidal volume and regular respiration. And the child should be having facial grimacing and purposeful eye opening. And it's especially useful for full stomach child, and when the child has got interdental wiring or surgical intervention with the danger of post-extubation airway obstruction. So what are the challenges for awake extubation? You have to be aware of the anesthesia depth. Most of the time, breath holding spasms and desaturation or bucking or post-extubation cup happens when you extubate the child in a lighter plane of anesthesia or when you stimulate the child at that plane. And invariably, deep awake extubation produces more stress response to the child than a deep extubation. And the incidence of emergence delirium may also be more. So what are the predictors of successful extubation? There are 5 predictors described, like a conjugate gaze, eye opening, facial grimace, purposeful movement, or spontaneous tidal volume more than 5 ml per kilogram body weight. So if you take all these 5 criteria, if you are satisfied with all these 5 criteria, then the chance of critical incidence is very rare and the positive predictive value is 100%. So if you look into one criteria of the among the 5 I described, the predictive values less. So the predictive value increases as you take into consideration more criteria. So what should be the criteria for deep extubation? The child should have a stable spontaneous respiration, and there should not be any response to suctioning of the oropharynx, and child should have a well-maintained spontaneous ventilation, and the airway should be cleared of secretions at the end of procedures. And most of the anesthesiologists prefer to have the child in the lateral position during deep extubation. Definitely, it produces smooth emergence, less coughing, and stress for the child. So what are the challenges for deep extubation? There is a risk of airway obstruction and airway aspiration, and most of the anesthesiologists prefer to have an oropharyngeal airway in situ before extubation in deep planes. And it's especially useful for reactive airway diseases or when the child has got a bronchopulmonary dysplasia. And sometimes anesthesiologists keep supraglottic airway devices before antagonism of the neuromuscular blockage when you are planned for deep extubation. So the question is asked whether you need awake extubation or deep extubation during post-tonsillectomy. So for that, you have to take into consideration the risk of bleeding and aspiration. Definitely the bleeding risk is less with the deep extubation, but the aspiration risk is more. And you also have to look into account what is the indications for tonsillectomy surgery. If the child has got recurrent obstructive sleep apnea or recurrence of infection, then it is better to go for awake extubation. So also in daycare procedures. And sometimes the anesthesiologists prefer to use a reinforced LMA or alpha-2 agonist for extubation during tonsillectomy. So this is an interesting study wherein they have used the alpha-2 agonist at 1 microgram per kilogram body weight at injection as a premedication, along with after premedication, and they found that tracheal extubation, when you extubate the child, deeply extubate child without alpha-2 agonist and with alpha-2 agonist, the incidence of the emergence phenomena is less when you use alpha-2 agonist. So whether we want to use conventional 100% oxygenation, is it the right thing at extubation? Ventilate the child with 100% oxygen. There is a lot of pro-con debate going on this topic. In short, the support for the continued use of 100% oxygen is that it maximizes the oxygen stores, so that in case of unanticipated difficult extubation, it will be useful. And AIDA still recommends 100% oxygenation at the peri-extubation period. But the problem with continuous use of 100% oxygen is that it can produce resorption atelectasis and even can reduce the coronary blood flow. And the reactive oxygen metabolites can accumulate. So there is a lot of debate for continued oxygenation, 100% oxygenation. Now, there are a lot of anesthesiologists using oxygen and air at the end of procedures instead of 100% oxygen. And the flow and duration of the, it has to be individualized depending on the case and comorbidities. What about any guidelines? There is IDA guidelines. It's basically for adults, but it look into stepwise approach for extubation in normal and difficult airways. I have just put these guidelines. It's there in the net. You can go. You can have a lot of reference for these guidelines. And basically, it's strongly advisable to ensure expert help before extubation in an anticipated difficult airway scenario. So what are the strategies for difficult extubation? You can have an LMA in situ while the child is still anesthetized, or you can have an extubation over a flexible bronchoscope, or you can use tracheal tube exchange catheters, or you can plan the extubation when you anticipate like airway edema. You can shift the child to an ICU and extubate the child. These are difficult airway algorithms for anticipated difficult extubations, IDA algorithms. Basically, they all look into 4 Ds and 3 S at the time of extubation. And you have to keep the airway catch during extubation. Once you identified that the child is likely to have a difficult airway, and also take into consideration patient is fully awake and obeying commands. So you can go for recruitment maneuvers of the lung, oxygen supplementation, extubate over a airway exchange catheter of FOB, or you can delay extubation as in case of absent leak test. So this is DAS guidelines for again for extubation guidelines, basic algorithms which take into consideration the you have to assess the airway and general risk factors. What are the airway risk factors and what are the general risk factors for the patient to extubate at the time of at the end of procedure, and you have to optimize patient and other factors at the end of procedure, and you have to risk stratify, and accordingly you can go for low risk algorithms or high risk algorithms. Again, thus guidelines for low risk algorithms and high risk algorithms. So in summary, you have to identify the risk factors and take adequate precautions. Extubation in a difficult airway scenario should be a meticulously planned procedure, and you have to look into conditions, intubation conditions and the risk of aspirations, and meticulous suction and inspection of the upper airway at the end of procedure. And depending on the scenario, you can plan for awake or deep extubation. And now the use of alpha-2 agonist or supraglottic airway devices has been described to facilitate extubation in difficult airway scenarios. But the success is always in quickly identifying and effective difficult airway scenarios and effectively oxygenating the child. Thank you for your patient listening.